The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. I am Tony Urbanek, and we are here for the next episode of TMD Demystified. Today, I am going to talk about the topic of treating TMD as a team effort. And truly, TMD is a team effort, treating the problem. We have solved this problem. I say that openly, not to self-aggrandize myself or our company or the device. It's a simple statement. I figured out what everyone else had not figured out and had missed and been dancing around for 60 years. And that is that all the symptoms are directly caused by inflammation. And if you can figure out a way to make the inflammation in the temporomandibular joint go down, go away, the symptoms will go away. That's the simplicity of it. And I challenge anybody to disprove that. And if you unload the joint long enough, significantly enough and long enough, the inflammation will subside, no matter what kind of damage is in the joint, no matter where the disc is, no matter how long the locking has been there, the symptoms will subside. But it is a team effort to bring this to any particular patient and make it work for any single particular patient. And it is a team effort, certainly, to bring it to the public so the public is aware of this, so that patients finally quit being run around in circles, trying to solve this plethora of symptoms and the conundrum of these symptoms that are apparently disparate, but absolutely connected to inflammation within the temporomandibular joint. So it's a team effort. All right, so it's a team. Who joins this team? Who are members of the team? Well, I've identified 4 members of the team, generic members. There's the doctor provider, the obvious. There's the patient themselves. There's the lab tech or lab technicians, the manufacturing lab, which I have a lot more to say about. And the 4th team member is the marketing team. Because if you have the best solution since sliced bread, but nobody knows about it, then it is not going to be a solution. Whether it be for a particular patient who has had the problem for 20 or 30 years and has run through 10 doctors or more, and finally given up and decided that they just have to live with their constant headaches and their shoulder pain and the ringing in their ears. They have not found out about it. They have not been made aware of it. And they have not been made aware of it primarily because their doctors who they go to try to solve this problem for them are not aware of it. So marketing plays a significant part in the team that has a solution for the problem. So let's kind of dissect this and unpackage it and talk about it item by item. So first, there's the provider. And by the way, each one of these team members and the concepts used in each team member, I have talked about extensively on prior episodes individually. But this episode I've done intentionally to kind of bring it all together in one place so that the viewer or the listener can understand that, there's more to it than just having a doctor know what to do or have the technology to do it or how to explain it, stuff like that. The doctor is only 1/4 of the solution, the technical solution, the clinical solution has been worked out. I just described that. And I challenge anybody to prove me wrong. Please prove me wrong. Anybody. But let's get to the point. So the doctor provider, he has to learn what I found out, what I learned. And I didn't discover anything. I didn't discover anything that hasn't been in the literature. I did not discover anything that other people don't know. What I did was, because of my extensive, broad background in medicine, in dentistry, and in academics, academic training, and in the sciences, and I was able to connect the dots and then look at it from 50,000 feet and see exactly what was missed. Once I found out what was missed, then I could explain it, and we came up with a simple solution. And obviously, I mentioned multiple times before, I challenged myself to look for the solution, but started with the patients, and my patients actually gave me the key where to look and what to do. When I did that, it worked, and then I had to figure out how it worked and what was going on. So I didn't discover anything, and actually I was the major contributor was not me, it was my patients. Covered in many different episodes, many different places, and that is explained voluminously. Doctor provider needs to know the technical qualities and aspects of inflammation, of the internal workings of the temporomandibular joint, the neurovascular system, how it's all connected to the central nervous system, and why inflammation in this joint then causes directly, frequently, reproducibly, frequent and recurring headaches, earaches, jaw pain, neck pain, upper back pain, ringing in the ears, a feeling of fullness in the ears, vertigo, dizziness, shoulder pain, arm, hand, finger tingling, and numbness and locking. There are more symptoms that later on we're going to talk about in its relationship to, quote, migraine headaches. Decreasing the inflammation in the temporomandibular joint significantly decreases bad headaches, which are more often than not diagnosed by someone else as a migraine headache. We don't fix migraine headaches. I'm not sure migraine headaches actually exist. That is a broad statement, but honestly, I am not sure. What we know is that the academics who study migraine headaches and write upon migraine headaches are the first ones to say, we don't know what causes migraine headaches. What I have said before, and I say again, we know that inflammation in the joint, temporomandibular joints, one or both sides, consistently cause really bad headaches that are more often than not confused with what are called migraine headaches. That is a fact. That's a fact and provable. So we don't treat migraine headaches, we treat TMD headaches. And the doctor who does that needs to know the pathophysiology, the anatomy that is well constructed and discussed and described on our online course. And in these episodes on this podcast that I've done multiple episodes in, describing all those aspects of it. It's there to listen, it's there to learn, it's there to watch and apply to your patients. So first, the doctor has to know it, and then they have to apply it as a provider. So that's what everyone thinks treating TMD is just the doctor needs to know what to do. Well, if the doctor does everything perfectly and they know what to do and they can apply the protocol, because the device itself is not just a widget that you stick in somebody's mouth. There's a protocol that goes with it. You got to know how to use it. And at times you have to know how to adjust it. Most of the time it's just 1, 2, 3, but occasionally you run into a patient where, again, thoroughly discussed elsewhere, you have to adjust it to unload a little bit more of the load on the temporomandibular joint to get the effect. Part of the course, part of the concept, part of the reason that you learn how to treat TMD with a posterior disc occluding device and protocol, better known as the Urbanic device. The second, and very important, I'm not sure who's most important on this list, but definitely very, very important on the team effort is the patient themselves. If you do not have a compliant patient, I can promise you it's not going to go well. It's not going to work at all, or it's maybe work a little bit and not go well. You have to have a compliant patient. Now, what I found after 43 years now of being an oral and maxillofacial surgeon, and for sure in the last 11 years where I focused consistently and exclusively on treating the temporomandibular joint non-surgically, is compliance with patients sometimes is hard to get. Frequently hard to get compliance with the patient. I don't know I won't kind of quote and throw a number out there that I'm not sure of. When I did 2,000 temporomandibular joint surgeries, or multiple kinds of other maxillofacial, major facial reconstruction surgeries, orthognathic surgery, did a couple thousand or more of those, did a whole boatload of cleft lip and cleft palate operations, bone grafts. I also did, 2,000 TMJ surgeries. Patient compliance was not a problem, because once they said, yeah, we'll do it, you take them to the operating room, you put them to sleep, and you just do it. And then you hope for the best. Hope you did it right. Hope the outcome is good. If you have a complication, you got to fix that. But doing surgery on patients, you did not have to worry much about compliance. Occasionally someone didn't take their antibiotic, or tried to fight against the intermaxillary fixation and broke their wires, stuff like that. But it wasn't something that was an everyday occurrence that we had to deal with. Most patients went through the system kind of fail-safe. But when you got into non-surgical treatment, especially a treatment where you have to wear a intraoral device consistently, that's starting out 24/7 for 2 months and then going indefinitely nighttime only. And some patients do have to wear it more during the day. 15% find they need to wear it more during the day when they're on a computer or in the traffic, is what they tell me. Compliance is a big issue. Sometimes the compliance is done, the non-compliance is done very unintentionally. I understand that. Very often, the non-compliance is done very intentionally, because patients have their own mind, and they do what they want to do. Most of it, I think, is because of not understanding. I don't think it's misunderstanding. Not in this practice, because I'm very careful and very, very secure in how I instruct patients, and it's in writing. It's all in the package insert also, but I'm very, very careful about how I instruct patients about what their responsibility is, how they need to act, what they need to expect. But after learning what I learned and doing it now for 11 years, I am also extremely aware that patients don't listen. You can talk slowly, you can talk carefully, you can watch them to make sure they're engaged with you and not thinking about something else. But consistently, patients will come back after a very thorough consultation, and they will make one comment or another that proves to me that they were not listening, or did not understand, or did not hear a point or points that I made in the consultation. The most common one that applies to a lot of things is the use of heat versus ice. I say, there are 3 things you can do other than the device itself, which is, soft food, non-steroidals for the first 2 weeks, after which they don't work anymore. And then the third is on and off heat. And those are for patients who I don't really want to do the device, or, I I need something else other than the device. And I said, well, I don't do surgery. I don't recommend surgery, but these are the 3 things you can do. And the third one is on and off heat, 10 minutes on, hour off, consistently. Patients will come back after I say that, and I say it 2 or 3 times to the patient. They will come back and say, I put ice on it and it just didn't seem to work. It's like, I didn't say ice. Proves my point about patient compliance. I don't think they do it intentionally, but there are patients who do it. They do what they want to do. I mean, they know they're supposed to wear it 24/7 for the first 2 months, and they don't. And most patients admit it. No, I'm not going to wear it, or I didn't wear it like he told me to. But they are in the minority. The majority are compliant. They try to help. It's their pain. They try to do everything they can. And I can say, without giving the numbers, I would say at least 2/3, maybe 3/4, maybe 8/10 are totally compliant. And they do exactly what you want them to do. And they consistently get reproducible, expected results all the way up the treatment plan, starting at 3 weeks after delivery, at 2 months after delivery, at 4 months after delivery. They do what they're expected to do, and they get the results that the practitioner provider is expecting. And they go right up the numbers of what percentage of their symptoms are gone, and they do it pretty predictably. But the patient has to know that they have a part to play in this, a significant part to play in this. It's a team effort, and you have to play your part. And I say that directly to patients, and everybody accepts it. Not everybody likes it. If you've been a practitioner of any kind for any length of time, you're already aware that people come in and they do not want to take any kind of responsibility for their own care. They come in, sit down, pay their money, fill out the forms, and whether they say it or not, what's in their mind is, fix me. Just fix me. Your responsibility is to fix me, and I'm here. I filled out the paper, I paid the money, or my insurance company paid the money. Fix me. It's common. Let's admit it. Let's talk about it. Let's get it behind us. Let's deal with it, and let's try to overcome it with the patients who are like that. And usually it comes out pretty quickly. The few people who are like that, they're not the majority, but there are folks who do that. And whether you like it or not, you're going to get some of those people. And so then you got to remind them that, no, it's not just fix me. You have a part to play in this. You have to be compliant. You have to be a good patient. And whether or not they like to hear that, and some people do not like to hear that. I have seen the frowns on their faces, or like I am the devil himself, because I tell them that they have a part to play in this. I do that. Maybe you're afraid to do that. I'm not. All right, so I think that kind of covers the patient's part to play in this, and what you can expect, what I've seen, what I've experienced, off and on, both surgically and especially non-surgically here in the past 11 years treating TMD. The next group who have a great part to play in treating TMD is the lab technician, singular, plural, and the manufacturing facility itself. Because my practice and the other doctors who I've taught to do this are now getting so busy doing this, the lab portion is increasingly important. As we increase volume, we found that there were significant difficulties in getting quality lab procedures done and devices completed. Recently, our company, TMJ Services, by design and by intention and necessity, opened up our own manufacturing facility, our own lab, and hired our own lab technicians. I just could not get the high quality and consistency of the construction of the very simple intraoral device that to you or someone across the room would say that, well, that looks like a retainer from the orthodontist. Of course, it's not a retainer. It has a totally different design. It has a patent on it, but from across the room, it looks like a retainer. A couple ball clasps on it, but the consistency of the manufacturer when this was subcontracted out to a very, very well known, and I like them a lot, and they tried to do a really good job, but I just could not get it, and so I was forced to bite the bullet and finance our own manufacturing facility, which turned out to be the right decision. And because now I have control of the quality and can instruct the lab technicians, and they are consistently only working on one device. And we're also doing quite a bit of R&D, how to improve, not the quality, but improve the efficiency and materials of the device itself. It's been a great advancement and a great boon, and we've only been doing this now for the past 4 months. But even so, we have made tremendous achievements by having our own lab techs, our own lab, and actually now are pursuing and will soon have FDA approval as an FDA approved laboratory in the United States of America. And that is a high standard, and there are very few dental labs in the country that achieve that moniker. Actually, to my knowledge, there are only 20 or so, roughly 20. When I first investigated having an FDA approved lab construct our FDA approved device, there were only 11. And now there are a few more, and our company is rapidly, and very soon we're on track to get that approval. So it's very, very significant to have lab technicians as part of the team that consistently can make the device, understand why they make it that way, and are very engaged in doing the additional R&D to make it better, to make it more predictable. The materials, the design is significantly unchanged, but those kinds of things, they add considerable improvement and importance to the team effort. So lab technicians, the lab itself, how the lab is arranged, who oversees the lab. My associate in the practice, Dr. Ed Urbina, is the director of the lab itself, has done an excellent job of organizing it and overseeing the technicians. He himself is a stellar example of a doctor who is very precise and wants to do whatever he does in a very precise and exact way. And I give him a lot of kudos, a lot of respect and appreciation for doing that for the company and for me. And then the fourth member of the team, which is equally important, I think, to the other three. Now, for those doctors out there who have big egos, who think that you're the most important part of the team, okay, I'll give you that. Somewhere along the line, I lost that. I don't know where. I can tell you I used to have it. I don't have it anymore. I just don't have it anymore. When I wanted to be a doctor, when I went through the training, extremely difficult training program of all those times and tests and degrees and challenges, both in dental school, medical school, academics, PhD, master's degree. I mean, I thought that, I was really important. I lost that. It's like, I happen to have a lot of information, and I try to apply it the best way I can, just like any person does in their business, in their job, in their family. But the marketing people who don't have degrees and may not even have a college education, or they may have PhDs, like Naomi in the organization. She has a PhD in education and has extremely high ability in training people and a lot of experience. But the marketing aspect of this problem, solving the problem of TMD, in my mind, is equally important, or maybe more, to the other three. Because if you have, and we go through this again, if you have a great doctor who knows exactly what to do, and I have an example of that right now. I had a conversation with a doctor in our network who knows exactly what to do, but he's not tuned into the marketing. He's a good doctor. He's extremely competent. He has regular old patients who I assume most of them are compliant. He is now given the best technology possible through our own lab now that we have control over it, but he is not tuned into the marketing, and we are trying to help him with that and actually do it for him in his practice. But the marketing part of this is equally as important to the other three. I think in a way more important, because if you can have all the other three things in place, but if the doctors who misdiagnose it, mistreat it, misdirect it, or the patients themselves who have been going around in circles for 5 years, 10 years, 20 years. I saw a patient yesterday, and I see patients on Monday. Today's Tuesday. I always do these episodes on Tuesday morning. And I saw a patient yesterday, who had 50 years of symptoms. And she is now, I forget what her number was. It was high. 85% of her symptoms are gone after using the device. But I have a few, she's not the only one, who had 50 years of symptoms, headache, earache, jaw pain, whatever they were, that have now gone away. She suffered with this for 50 years because she didn't know it. And one of the remarks I hear constantly, I wish I would have known about this 10 years ago. I didn't make that up. Patients say it to me face to face. I hear it constantly from patients. Once we relieve their symptoms, they look up, and we gather the number, what percentage of your overall symptoms are now diminished or decreased, and frequently out of their mouth, I wish I would have known about this a long time ago. That is the challenge. We have solved having a good provider. We have many of those now, expanding from the Southeast into the Midwest, into the East Coast, and now we're going toward the West Coast and developing a network of doctor providers. We have actually an increasing number. We have, I know how to get patient compliance. We now have our own lab. That is all under control. What the challenge is getting the awareness out there to the doctors who misdiagnose it, mistreat it, misdirect it, and the patients who consistently say, I wish I would have known about this 10 years ago, 20 years ago, 30 years ago. I've described the marketing program in another issue. I'll just direct you to that episode. I'm not going to try to repeat it exclusively or again, hate repeating myself. And I do even though I intend to do. But the marketing program has been the challenge. We have overcome that. We know what to do. It's about teaching others to do it. And the marketing program is not directed primarily at marketing to the public, although there is some of that going on Google AdWords and Facebook and social media and things like that. We do some of that, but that is not where the vast majority of people hear about us. The vast majority of people hear about us and actually get the solution by marketing to the doctors, well-intentioned doctors out there who misdiagnose it, misdirect it, and mistreat it, and don't know it for what it is, TMD. And the way we do that is letters go out every time the patient comes in to see us to their doctor list, describing what their patients were, their symptoms were, describing what their symptoms were or are, and what percentage of those symptoms are now diminished or decreased by unloading the joint with a disc-occluding device and protocol, better known as the Urbanic device. Letters out with stamps on them. And then you accumulate a huge number of doctors who then recognize TMD when it occurs, when it's there, and they recognize when they, in the past, have misdiagnosed it or mistreated it, and they send it to us for appropriate treatment. That's the marketing program. The awareness program, I prefer awareness rather than marketing. Marketing in the doctor's environment seems to be not like it used to, a dirty word. The hospitals market, the doctors market, the orthopedic surgeons market. There are services abundantly nowadays, but still it's not considered, a part of medicine really, but it is, because if the patients don't know about it, if the doctors don't know about it, then it's going nowhere, and no one will be fixed, and no one will have the advantages of getting their symptoms relieved. So it's a team effort. It's a team effort, and it's a team effort from a company standpoint, the developer standpoint, that you have to have good members of the team who understand it. And it's a team effort from an individual standpoint. Each member of these 4 categories, category meaning doctor, provider, patient, lab tech, and manufacturing facility, and then the marketing arm, the marketing program, making people aware of this. We all, as individuals and as a group, have to work as a team to get the job done, to get the word out, to get the training done, to get the understanding in, to get the misunderstanding out of how to treat this. That's a huge portion, because there's a lot of misunderstanding. I recently watched the most recent presentation from the American Association of Oral and Maxillofacial Surgeons, what surgeons think about TMD and how they treat it. I won't make any disparaging comments about it, but this is the most recent, literally right off the press video series put on by my home organization, American Association of Oral and Maxillofacial Surgeons, that didn't even comment on the effect of inflammation within the temporomandibular joint. Just ignored it. I mean, didn't even cover it, didn't even comment on it, talked about all kind of other things that aren't helpful. Although a whole hour program went on, it just didn't cover what I cover with you every week and instruct on every week and in our course. A lot of misinformation going in different directions that isn't helpful. And I won't say any more about it. And American Association of Oral Maxillofacial Surgeons, which has a bias on surgery. I am a surgeon. I do not do maxillofacial surgery anymore. I decided, because of my age and because I've done enough. I've focused on non-temporomandibular joint. I focus on non-surgical treatment of temporomandibular joint because of what I discovered, what we do. I think I've explained my position. I've explained, very important. I think this is a very important episode, generally speaking, for anybody who's interested in helping people, helping yourself, your practice, developing an expertise in treating temporomandibular joint disease, understanding the disease itself, and getting rid of the misunderstandings about this problem, which are literally not taught anywhere, certainly not taught in dental school, and taught in fragments in different areas, all of which have different biases because of where they're teaching it from and what they're doing. So treating TMD is a team effort. That's a fact. And if you have a good team, if you know who your team members are, you will be successful in treating this problem. I'm Tony Urbanek. This is the latest episode of TMD Demystified. I look forward to speaking with you on a different topic in 1 week. I hope you all have a wonderful week, a very successful week for your practice.